so I'm going to try to go through this as fast as I can. Hi everyone, my name is Sarah Tucker. I'm the Chancellor of Higher Education for the state of West Virginia. Thank you all for joining us today for our third annual summit designed to address topics critical to healthcare and health science education in West Virginia. This event is coordinated by our Health Science Division, which is committed to growing the healthcare workforce in our state. As you know, we have made and continue to make good progress in areas like behavioral health and emergency medical services, but there is still so much more to be done to create the workforce that we need to keep West Virginians healthy and cared for. This year, I'm excited that the summit is focusing on population health and how we can best plan ahead to make sure our future workforce is exactly what we need. I'm a higher education person, not at all a healthcare expert. So I'm going to leave that up to all of you in this room. But what I do know is that any approach aimed at improving the health of an entire population is a good approach. This is about improving health outcomes for all West Virginians, removing inequalities in care and bringing partners together to deliver that care more seamlessly. It includes focusing on wellness instead of sick care, using data more effectively to improve care, better engaging patients in their own care, and better coordinating care that was previously siloed and fragmented. Today, I hope you'll dive deep into questions about how we get there. How can health sciences education evolve so that we're addressing the skills needed to provide population-based care? How can we think differently and prepare our students in ways we haven't previously imagined? Clinicians, educators, advocates, and healthcare leaders alike need to be able to work with and across stakeholder groups to assure that the workforce is well prepared for this shift. So today is just about that. You'll hear from a panel of those doing population health work about what they've learned regarding the needs of the workforce. You'll hear from leaders about our current workforce and special considerations for the workforce of the future, including how you can create a resilient workforce. You'll have an opportunity to hear about successful population health initiatives from our Koester presenters, and we challenge you to ask them as well what they need for their workforce in order to be successful. And finally, you will have some time to brainstorm with your peers to see how each of us can contribute to creating the workforce we need. Thank you all for what you do and for being here, and I hope you have a wonderful summit.
Good morning, and thanks again for being here. I'm Carolyn with the Health Sciences Division at the Higher Education Policy Commission. If you're not familiar with who we are at Higher Education Policy Commission, please snag one of us at the table in the back and just ask us. We will be happy to tell you a little bit more about what we do for higher education there. I'm excited to be here today. I think we have a really great schedule for you. There are agendas in the back if you don't have one. There's also here on the screen. We are going to be learning together today, and so I'm excited to do that with such a diverse group who has joined us. Before we get started, I just wanted to provide a couple of definitions because we will be talking about population health and the population health workforce. So when our panel begins, they're going to go into a little bit more depth about some of these terms, but we do have some basic definitions around population health and population health workforce. It's a diverse workforce. Many of these professions are represented in the room today, and we have a lot of expertise from lots of different sectors of health. And so again, we're very happy for you to be here. Just to cover a couple of logistical things, the restrooms are back this hallway in the back here. If you go through the exit sign, please everybody get a lunch. If you came in late, please don't be shy. Go ahead and get yourself a lunch. There are also drinks in the back. If you need anything, please see our table back here. And before we get started, as you have a few minutes to look at the definitions here, we are going to play just a quick explainer video that talks a little bit about population health. We searched to see if there was a video like this from one of the institutions in West Virginia, and we did not find one. And so you'll see these are from out-of-state institutions. So just putting that out there in case anyone who has population health or public health programs is interested in developing something like this in the future.
The world is facing more complex public health challenges than ever. From persistent crises, like the obesity, opioid, and gun violence epidemics, to emerging crises, like the COVID-19 pandemic, we can solve our public health challenges by focusing on the multiple factors that influence the health of large groups and communities. Population health is rooted in the science of understanding the multiple determinants of health, from cell to society. Population health is a convergent science. It brings together relevant academic disciplines like epidemiology, psychology, sociology, economics, political science, engineering, and biomedical sciences to drive the innovations and interventions needed to create better health outcomes in communities everywhere. Population health prioritizes and advances equity because it shines a spotlight on an overlooked scientific fact. Zip codes are better predictors of overall health than genetic codes. Population health is changing the world, one community at a time, and helping millions of people around the world achieve better health outcomes. To learn more about population health and how you can join the population health workforce of the future, visit health.lehigh.edu.
We have another video that we'll show you here in a moment too. But we chose a couple different videos that we thought would help describe population health to students. And so many of you in the audience are educators, and so we just wanted to provide these as examples. So.
A population shares common circumstances like where they live, or their genetics, or even their health. The health of a population is impacted by many, many factors. The environment, public policies, social services, and racial, income, and housing inequities, to name a few. Population health science is a discipline that investigates these factors to diagnose what's impacting the health of a population and how to improve it. Population health professionals analyze everything, looking for key insights, and then bridging the information gaps between scientists, health professionals, social services, government policymakers, and the public. The population health approach improves more than just health outcomes. It also helps communities use their resources wisely and fairly. By creating healthier systems at the population level, we in turn improve health for even more individuals with each intervention. Population health professionals are intuitive leaders with skills like project managers. They see the big picture across many different fields and disciplines and possess the knowledge and ability to bring resources, data, and information together for better solutions. Career paths are extremely versatile, and opportunities will be guided by the degree you choose. Earning a Master of Science in Population Health Sciences enables you to execute the research and analyze the data that helps us understand particular populations and their health needs. A Master of Public Health prepares you to work as a public health practitioner, taking action in communities and health settings to implement population-based health solutions. With expertise in population health, you too can help lead whole populations to better health and longer, happier lives.
All right, so now that we have kind of some common understandings, I'm going to go ahead and introduce our moderator for the panel. I would like to introduce Dr. Cynthia Persily, the incoming Secretary of West Virginia Department of Human Services.
Good morning, everyone, and thank you for joining us. It's so nice to see lots and lots of familiar faces, and I know some of you who are doing some really great population health work. So I'm going to ask our panelists to come up and join us at the table as I just do a little intro to the panel. And just wanted to echo a little bit of what Carolyn just said and what Chancellor Tucker just said. But population health is really all about maximizing those health outcomes in a community. And improving population health means connecting practice with policy. It means developing some non-traditional partnerships that help us push the health of the population forward. And those partners are pretty wide-ranging. You can sit any place, it doesn't matter. I'll just call you by name.
All right.
We've brought some of those partners together to talk about the population health work that they have been involved in, and what they see as the skills needed in the workforce in order to have successful population health initiatives. So today, what we're going to do is we're going to have a series of questions. I'm going to direct them at one panelist to start us off, and others will jump in. We haven't rehearsed this, so hang in with us. We did have some pretty lively planning calls, though. Before we start, though, wanted to introduce to you Tad Haynes. Tad Haynes is of Unicare, one of our Medicaid managed care organizations, and he's going to provide you with some definitions to keep us all straight when we're using this new language related to population health. And then what I'm going to do is, Tad, I'm going to just ask you to introduce yourself, and then you start with what you're doing at Unicare related to population health. Each of our panelists are going to introduce themselves in the interest of time and talk a little bit about, to get us started and give you some context, what are they doing in their organizations. So we have representatives of insurers, of philanthropy, of providers, of public health, and partnerships that will all talk to you about what they're doing, and then we'll start in with our questions. So Tad, you want to introduce yourself, give us the definitions, and launch right into what Unicare is doing.
Absolutely, yeah. I'm Tad Haynes. I'm president of Unicare Health Plan of West Virginia. We're a Medicaid managed care organization. We serve about 200,000 members throughout West Virginia. We're caring for the most vulnerable of our population. So this is a subject that really excites us. This is something that we have, we've talked about, we've worked on for years, but now there's some organization around it. There's some energy around it. I think it's great that we're having this conversation today, and it really reiterates that point that we need to put some additional focus here. And I don't think I can do better than the videos, but I'll take a stab, because I think population health is such a big subject area. We tend to, especially if you're not in the delivery system, if you're not a clinician, some of these terms can get a little confusing and we can misuse them sometimes. So, public health, I think we all get it. We all lived through COVID. We know what public health is. That's focusing on, making everybody healthy. Immunization programs, we're putting fluoride in water. That's public health. Population health, that's focusing on the health outcomes of a group of individuals. So the nuance here is how we're defining that population. So keeping in mind Medicaid managed care plan, our population is vulnerable folks in the Medicaid population. You can bucket that in different ways, and that's where things get a little quirky, get a little nuanced. Community health, it's exactly what it sounds like. That's looking at the overall health of where people live, work, and play. That's a really easy one. SDOH, social drivers of health, social determinants of health. Our organization tends to call them social drivers of health because we don't feel like that those factors have to determine your ultimate outcome. So they're definitely a part of the conversation. They're definitely driving a person's health, but with proper interventions, we can do something about that. And one of the videos touched on this, but I think this is just an amazing statistic that 80% of a person's overall health is determined by these SDOH needs. So that's something, as we have conversations today, we have to keep in mind. Whole health, holistic view of health, physical health, behavioral health, SDOH needs, pharmacy needs. That's taking into account everything that a person needs for their overall whole health. And health equity, lots of times this one gets confused with health equality. I think everybody here would agree everybody deserves their best chance at health. So that's not equity. Equity is giving a person the thing that they need that may be a little different than another person in order to have the best chance at health. So that's a real important one, and we've heard that term used a lot more in recent years, and that's really exciting. Again, these are all interconnected. They all feed into each other, but there are definitely some nuances we got to keep in mind.
Can you talk to us a little bit about what you're doing at Unicare? Population health?
Absolutely. As I said a minute ago, it's something that we focused on for years. Now we've got some names for it. Now it's a focus of the entire delivery system. You know, we are doing things, as I said earlier, we're dealing with the most vulnerable folks in our state. So these are folks with income challenges, these are folks with housing challenges, food challenges. So just one quick example, you know, we get data from the state upon enrollment from the Medicaid program, and one of the screening questions is, do you have enough to eat? Have you struggled with hunger in the last 6 months, I believe is the time frame. So when we see that, that's a hard sign. We're not talking to them about anything else other than what do we need to do to make sure you've got food? How do we get you emergency services? Even if we've got to deliver a box of food, how do we make sure you're connected in the community? So that's just one small example of where we're trying to address SDOHDs for our members.
Great, thank you. Kim Tieman, you want to introduce yourself and tell us what the Benedum Foundation is doing related to population health?
Okay, 4 days from now, we'll be done. No, I'm teasing. So I'm Kim Tieman, and I'm the Vice President and Program Director for Health at the Benedum Foundation. And I see Dr. Rhodes is over there. He's one of our board members, so he can talk to you more about the foundation as well. And pretty much everything that Thad said, we're doing some of that. But at the Benedum Foundation, we have had health as a focus area since our inception 79 years ago, because Claude Worthington Benedum died in the first big pandemic, the Great Flu pandemic. And so we've always had this as a core tenet of what we want to do. So we really try to focus on policy, system, and environmental change. And so we fund everything from the food bank system in the state to make sure that we have food, the disaster preparedness so that if something terrible happens, like a flood, that people are prepared. We convene other funders. We try to be partners with government. We fund so many projects that I would love to tell you about, but let me give you a couple. So we've been trying to work on prevention, intervention, and treatment. So we fund in those spaces. So one of our prevention and intervention projects is with Dr. Jamie Jeffrey, who's in the room as well, with CAMC and Keys for Healthy Kids, as we're looking at having children who are 8 and 10 developing type 2 diabetes. This is an unacceptable thing. And so how do we change that? Unicare's been a partner with us on this, and Thad may not even know it. Now we have funded some of the Fresh Connect, you know, just doing farmers markets, getting access to real food from our farms. We are currently creating central kitchens to work on that issue. So it's not just what happens in the doctor's office, but it's what's happening on the child's plate or in school, making sure that we're physically active. We also, like during COVID, there were 6 health funders in the state when I started at Benedum that identified as a private foundation or that did that. There are now 12. That's exciting. That's in a 13-year period. And that's a lot because of hospital conversion. But what we can do that government can't do is we can do demonstrations and pilots and things like that to say that these things work. We care a lot about data. Cindy, I know you care a lot about data, because if you don't have a benchmark, then if you don't have a path, it's Alice in Wonderland. Any road's gonna get you there. And you have no accountability. We also fund the safety nets like that I was talking about. So we fund FQHC system, free clinic system, and health department system. When COVID happened, now our typical grant's about 100,000, but a lot of the other foundations in the state, their typical grant may be 10,000. So we were able, now think when that happened, we were able to stop, get together, stop all funding that we were doing, and we redirected over $2.6 million to the COVID epidemic to fight, to make sure we had immunizations. We also are doing a lot around minority health and minority health equity. And then we just help, like a critical access hospital that really wants to expand, like Pocahontas Memorial, that's like, we are seeing our women not getting mammographies and you know, the services that they need. So we sometimes do fund up starting for a doc, because we know a doc can pay for themselves because it's billable. And that's another thing that funders also want, and we particularly, we don't fund things that we can't sustain. And then if you want, you can go to the first poster over here later and learn about our chronic care management community health worker model that is fully sustainable, that has really been translated now to all chronic disease, from congestive heart failure, COPD, diabetes, to substance use, and we are getting ready to start one with Dr. Jeffrey's clinics with children. So HRSA's pretty excited that we're looking at going upstream and trying to stop all of the diabetes that we're gonna have later on. So I could go on forever, but I'm pretty sure you don't want me to, so.
We would love to, we'll do that on another day.
Okay.
Thank you. Michelle Coon with Vandalia Health.
All right, good morning, and thank you for allowing, so sorry, I don't know if this will be loud enough. Thank you for allowing me the opportunity to share information this morning. So Vandalia Health Network, we are a clinically integrated network that is statewide in West Virginia. We were formed 5 years ago. CAMC is our parent organization. They saw the need. They knew as a tertiary care facility that they needed to make sure that when their patients went back into the communities that they were referred to them from, that they had the resources they needed, because at the end of the day, as Pat mentioned, social determinants of health are a key driver. So we needed to make sure we were connecting the dots. So the clinically integrated network was formed. Our team is made up of practice transformation team members, and some of those are with me today. And what they do is they work with the hospital and provider organizations to make sure they understand and have the resources they need for their patients to connect the dots. And then we have care managers and care coordinators who they are the face for the patients. They're the ones that are doing social determinants of health screenings, finding out why that chronic COPD patient is having a relapse. Why are they back in the hospital? What do they need? And a lot of times it's resources that we don't probably in this room think a whole lot about as something that would be hard to obtain. And so they're making sure they have the healthy meals, that they understand what a healthy meal is. So we've been able, through our organization, we have about 139,000 patients in West Virginia that we manage population health for in building those bridges. And so we work with folks like our pair partners like Unicare and others to do pop-up pharmacy events in the communities that's bringing fresh fruits and veggies into those food deserts in our state, and making sure not only do we give them a box of food, but do they know how to use the box of food. I love fried zucchini. Is that the best option? No. Right, so we teach the healthier ways to integrate that into your diet. But then we're also working with them to make sure that they have transportation. Why didn't they make that doctor's appointment for their mammography? Well, maybe they didn't have transportation. Maybe there's not one local. So then we work with other partners to get mobile services into their community. So the video, fabulous, because at the end of the day, it's the community where it starts and what resources are in the community. So thank you so much for letting us be part of today.
Thank you. Thanks, Michelle. Thanks for being here. We'll go to Deb Koester, who is representing local health departments today.
Good afternoon, everyone. My name is Deb Koester, and I am Executive Director of West Virginia Local Health Incorporated. This is a 501c3 organization that was established in 1997, specifically for the purpose of supporting the local public health system across the state. I've been with the organization since 2012 and through the pandemic. So busy and long couple of years for us. Local Health Inc. Works with community-based organizations. We work with healthcare systems on community planning, but by and large, a primary mission of the organization is to work with and support the West Virginia Association of Local Health Departments and our governmental public health system at the local level. Our local public health system is 48 local health departments. They are primarily at the county level, but we have a few that are regional or have multiple counties. And they are part of the political subdivision of the county. We are in a decentralized local public health system in the state. That doesn't mean they don't work very, very closely with our State Bureau for Public Health. In our local health departments, as you can imagine, some are much larger than others, and many are in our small rural communities. Regardless of the size of that health department, they are all delivering basic public health services. And they typically will have for a workforce an administrator that is working under the direction of a board of health. And then they will have a public health nurse who's as Tad mentioned, focused on the immunizations and some disease investigation and surveillance. They usually have a regional or local epidemiologist, a sanitarian, Sometimes they will have other roles such as health promotion or harm reduction or other specific programs like that. An important part of local health departments and the work they do, however, is meeting the community and the partners and the public where they are. They conduct community health assessments with their partners. So this is where they are out in the community and really driving that population health through community health improvement planning. So that is always an opportunity to leverage those local partnerships. I think they will soon be even strengthening more the way in which they integrate assessment of social determinants of health into the work that they do. And we have some new relationships with our MCO payers to understand how we can partner and address population health there as well. So thank you for having me.
Thank you, Deb. And then we'll turn it over to Terry Cox with Partners in Health Network.
Good afternoon. It's just right afternoon now, so I'll say good afternoon. My name is Terry Cox. I am the Executive Director of Partners in Health Network. We are a partnership of about 35 different healthcare entities around the state. We've been around since 1995, and we try to pull together our resources. We are competitors sometimes outside of Partners in Health, but we are collaborators when we come together. So we try to do projects together that would benefit our members and our patients. So one of the things that we just wrapped up a 5-year CMMS project that we did on social determinants of health. We were able to extend that into a no-cost 6-year. But we did screenings. We had all of our participants screening patients as they came in at the point of entry into the facilities. And then we took that screening data and we then randomized certain people into the study, and they were provided navigational services. So we actually, through the grant funding, we paid navigators to drive those folks to help them get to resources. So we actually picked up the phone and called individuals and tried to get them to the resources. In order to do that, we had to build an extensive database of those resources, and those were changing, especially during the pandemic. We saw folks running out of money for utility assistance and for food banks running out of food and things like that. So we were constantly trying to retool our database to keep up with the demand and with the changing resources. The idea of this whole demonstration project from CMS standpoint is to determine if these social determinants, and probably going to start calling them social drivers now, thank you for that. To see if we can bend the curve on healthcare costs in the form of keeping the patients healthier, keeping them out of the emergency rooms. So all of these patients that were entered in the study had at least 2 ER visits. So we were able to get ER data from CAMC. We called those patients. We actually hired phone screeners during the pandemic, so we can call those patients. Obviously, the ERs are too busy to give them a social determinants questionnaire as they're trying to treat them in an emergency room. So we were able to call those patients after the fact, and it's hard to get hold of them sometimes. They don't have phones. They don't have a lot of times they don't have phones. They don't have access to things. But I think the program was very successful. We had a lot of success stories. You might have heard some of these. We presented a couple times in different venues on the work we did there. Other projects that we do together, and Benedum is a good funder for us. We appreciate their assistance. But we also work on pulmonary health and pulmonary rehabilitation. So we try to get our pulmonary rehabilitation sites to collaborate, to share information and ideas. And we're doing a program now called Catch My Breath, which I'm really excited about, and Dr. Young is excited about it. She's talked about it many times. We started with a grant from the Sisters of Palatine Foundation, and we just started in a small 5 or 6 county catchment area. We're up to 7 or 8 counties now, and we've got an initiative now to go statewide, thanks to Kim's vision, partly her vision,
Partly
Dr.
Dr. Christensen's, partly Dr. Young's.
So we're excited about this. We want to be able to take this model. So the Catch My Breath program is for anti-vaping, anti-tobacco program that we're gearing towards middle-aged school kids because it's an educational thing, right? If we don't start bending the curve while they're young and educating them on the dangers of smoking and tobacco use, and nowadays it's vaping. Okay? When I was young, it was all tobacco use. I worked for the American Heart Association when I was in high school, and we taught anti-tobacco use. Now it's vaping, and you'll see those all over the place, and we're trying to educate our kids on how not to vape. So we're partnering with our local FQHCs, our school-based programs, and we're taking these programs into the schools and actually teaching the kids. And so they're getting the only way you can really measure your success here is their attitudes towards vaping when you start the program, and then kind of their attitude towards vaping at the end of the program. So, and we pay those schools, we'll go out and hand out a check to the schools for their participation for the number of kids that they put through the program. We were paying them about $10 a student. And so now we're going to take this statewide with our help from our state partners and other folks. It's not just Partners in Health that'll be doing this, it'll be several partners throughout the state. But I think we're going to be responsible for, I don't know how many, 10 or 12 counties for Partners in Health driving this, and other people will be responsible for other counties. But all this is just trying to bend the curve a little bit on the, from a social drivers of health standpoint, and trying to educate our folks a little bit. But that's a little bit about Partners in Health. I'll be available if anybody wants to learn more about Partners in Health. Probably not already heard of the city. So.
Thank you, Terry. So we're going to start with a little bit of Q&A, and I'm going to throw it to one of our the questions to one of our panelists, and then I'm going to ask the other panelists to jump in. But what I want to remind us is something that Carolyn said this morning, and that is that the Higher Education Policy Commission is about helping to create that workforce for the future for healthcare. And so population health, as you can see, it's perhaps different than the way that we educated people in the past. And so Michelle, I'm going to start with you and ask you to just jump into this and tell us a little bit about the skills that you think we need to instill in our workforce in order to be successful with transforming our care model from an individually focused model to a community focused model.
Right. So for us at the network, we always refer to ourselves as bridge builders because you have to work with others in the community, whether it be partnerships or collaborators, to obtain the resources. So I think that for us, as we look at the employees that we hire for today, and also for what we're going to be looking at to grow in the future, some of the key components, they have to be good listeners. You have to listen to the patient. If you do not have your listening ears on, as I tell my children, you are not hearing what I'm saying. So you really are not understanding what I mean or what I need, right? So they have to be good listeners. They have to be able to communicate. And communicating isn't communicating at a scholarly level, but communicating and meeting that person where they're at. And I think that's just instrumental in that role. And being part of the community. The community health workers that you referenced, Kim, we have to have those, right? Because you have to be able to meet the patients where they are. So these are folks within your community. These are not, I think for us and our team, everyone on our team is not a four-year graduate with a master's degree. We have folks from all levels because that's important, and they each bring something instrumental to the table that the member who's at the center of all of it needs to get what they need.
Thank you. Others? Comments?
I would add, when I was thinking about this question, I thought about things that we get asked to fund all the time, or the conversations I have with people. I was just having lunch last week with the president of the Hospital Association, and it's the same issue that he was bringing up that I hear from our FQs or our free clinics, and it's leadership. How do we really teach leadership skills, and how do we get nurses to see themselves as leaders in the care team? How do we really do succession planning for our nonprofit sector in general, but it's really come to fruition. When you look at our FQs in the state, we've had almost a complete turnover from when they started to now. And so what are we doing to teach leadership skills, team building, motivational interviewing, those kinds of things that are just gonna be good for you for life, but it's really important that people know how to do that. Really glad that you said listening, and that's something West Virginians are good at. You know, we're storytellers, we love to listen about your family, we genuinely care. So how do we get people to be good interviewers, to get out of that patient what we really need to know so that we can address the SDOH, drivers or determinants, whichever one you want to do.
Yeah, that's a motivational interview, and I think that's a big one, and I'll give a quick example. We, you know, I mentioned the screeners earlier, information we get from the state on things that the member has identified, this is a need, got a housing need, transportation need, and I was in a meeting a couple weeks ago with some of our care teams, and they mentioned, you know, we keep calling these folks and they're telling us they're good. They don't have any needs. Okay. Well, we've got a sheet here that says something different. They're on Medicaid, so more than likely they probably have at least an employment need. So we've had to work with them to ask the extra question in a compassionate way, because we get it. Appalachian culture, we're prideful people. No one wants to say, hey, I need help. So that is something that, you know, the motivational interview piece is key.
And I'll just add, from the public health perspective, at the national level, we have core public health competencies. And there are 56 of them. They were developed in the 1990s, and the last reiteration was 2021. And those really provide a framework for building skills with the public health workforce. But I've listed each of those 8 domains for you. I think it would be hard to argue that they don't also apply to our population health workforce, from using data to systems thinking to community partnership building to health equity to community planning. So all of these domains, I think, are really applicable as we talk about building a population health workforce as well.
Terry, you said something when we were having our planning meeting around this question that I wrote down, and it was finding a path when one did not exist before. Can you talk a little bit about how you all were able to do that? And you know, that's a soft skill, but such an important skill.
Yeah, so, you know, you have to be very innovative and, you know, have a workforce that can not only communicate, but can understand the need of that patient or that population, and then figure out how can I pull the resources, how can I build a bridge to where I can get to. You know, maybe I need to bring in some other partners, I might need to invent another pathway that didn't exist before. So you really need some ingenuity. Not everybody has the same need. You know, we had people that had some unique needs we did not anticipate. You know, and to Pat's point, our interviewers had to be able to meet the people, you know, conversationally where they were, and had the skill to ask that extra question. But there's not always a specific resource. You know, if a child needs a bed, you know, we did things like that. We made sure a kid got a bed one time. They had always slept on the floor. And so, you know, our people tended to get emotionally involved, and you know, you got to be able to spread. You only have so much resources, so you've got to, you know, do what you can for the most people. But sometimes you just kind of go down that pathway, and you do what you need to do to help that person. And so there are some incredible stories that came out of our navigators that help these folks. But yeah, it seems like every case is a unique case, and you have to figure something out. So you got to have people that think on their feet and give that compassionate care.
Thank you. I think that's a rich set of skills that we may not be thinking about very consciously and instilling in our workforce, in our students, but we need to really think about that going forward to create that workforce. So I'm going to throw one out to Dr. Koester, and just from your public health perspective, which of course, as we talked, you know, everything that happens in local health departments is about population health. How has the workforce changed since the pandemic? And how do we reach students or those who are in career transitions to recruit them into this work?
So prior to the pandemic, our local, we call local public health, all of our local health departments, our entire local public health population of the workforce was a little less than 500. At the height of the pandemic, it was nearing about 880 to 900, and now we're seeing that contract now because we had to expand that workforce in order to mount and sustain for quite some time that public health emergency response. In terms of how the workforce has changed, we have seen work turnover, and I think that's a really important point. Kim mentioned that with community health centers. We've seen the same thing with local health departments. Since the beginning of the pandemic, of those 48 administrators, 22 of them are new today. So when we talk about building skills and looking, building skills among students, that opportunity for local public health leadership is certainly there. One of the other things that I think the pandemic really prompted us to realize quickly was with the visibility of local health, how important those community partnerships are and building those skills among the community partners. In early 2021, if you all recall, we vaccinated our elderly, our older adults first. And as that vaccine was coming in, and we were working at the Joint Interagency Task Force, and there was a charge to get that vaccine out across the state. West Virginia partners at the community level know their communities the best, and they know how to work together. And they literally had about 7 to 10 days in each of the 55 states to come together and develop a local leadership planning team to determine how to do mass vaccination. And we did it well. So I think, all of those core competencies in terms of attracting students, there are so many different disciplines within public health, but we are growing and changing. We're always a growing and changing, workforce. There are always new emerging public health threats. So I think we have all of that now to build on.
Thanks. I think that goes back to something that Michelle said earlier, and that was that it's not just 4-year degree and master's prepared people who are doing this work, but it is people who live in communities and understand the needs of the communities. So let's get them engaged in our local public health departments as well. So Kim, I'm gonna throw one out to you. So you talked a little bit about community health workers, but there are other new roles. What are they? What can be created, or what existing roles can be enhanced for population health care? And how do we deepen those partnerships that we've all been talking about so that these roles can be fully realized within our system? And then, as if that's not enough, how do we fund those opportunities for education, for training, for population health programs? So you've got a big one.
Yeah, I'll try to be succinct here, but I'm glad you kind of mentioned the community health worker. I always say to folks, we say words like case management or substance use disorder or community health worker, and everybody gets a picture in their head. It's just not the same picture. So everybody is not really on the same page, but they shake their head like, I know what you're talking about. I doubt that you do. So basically, I would say that it's a continuum. And on that continuum, we have all kinds of community health workers. We have that person at church that learns to use an AED. That's a really important lay professional that they know a skill and they're gonna save a life. We have peer support specialists that are paid professions now for people that have lived experience in substance use disorder. That's a career that didn't used to exist. It wasn't here before. So now here's this opportunity, and thankfully our state is helping to pay for that once you go through the certification process. And some of those folks are not eligible for other jobs because of past felonies or other things. So that really is this helpful way. You've got, right from the start, home visiting programs, parents as teachers, all of our My How, all of those programs that go into homes that focus on early childhood. Those are community health workers. And then there's the chronic care management community health workers. So that's just one. But what are those entry levels that we can connect people through micro-credentialing or through 2+2 or career pathways that you can try on a health allied career without signing up to be a doc? There's all kinds of ways. I asked forever, why can't we get kids to graduate high school being an LPN? And then everybody's like, well, can we have to be in the seat in face-to-face? But in our ends, you didn't have to. You could do it all online. Didn't make any sense to me. But anyway, I think that there are opportunities there. I want to throw out, when I don't know how to fund something, I go to the federal government and try to figure out who funds it there and how do the dollars flow to our state. So I have just purposefully become friends with HRSA, and that sounds like something that you can't do on any given day, but actually I have people at HRSA that I just send them a question. Who in your department does workforce issues on behavioral health? We have a behavioral health crisis in the state. I need help. What are these answers? So call your feds, whether it's SAMHSA or HRSA. I know that sounds like, how do you find the right person? What I found is generally there's no wrong door. You find them, they say, well, it's not me, it's Sherry. I'm going to connect you to Sherry. And you get that email. The other thing is the Rural Health Information Hub that HRSA funds. It's their job to every day help to connect you to resources. So you really should make friends with them. I call them all the time and I'm like, can you search the Federal Register and find something for me? And they magically do it. And they're happy that you actually cared and knew that they existed. So that's there. And then the other thing I want to throw out is, I'm so excited about this Grow Your Own Teach West Virginia program. I just think that this is, and I think, Dr. Rhodes, this was one of your favorite grants that we participated in with government, but we're growing our own teachers. We have a teacher shortage, and I'm thinking this is amazing. This is exactly what we should be doing. We should be growing our own teachers, making this happen, and getting them through that degree plan. Hurry up and do it, because we need to do it for social workers, therapists, nurses, and doctors, and psychiatrists. So let's stay tuned to that, let's support that, and let's figure out how we can expand that. That would be one of my thoughts. I'll stop there.
Great. Other emerging professions that anyone wants to talk about?
Yeah, I think Kim hit on a couple of real important points. Definitely emerging career opportunities that we've not seen in the past, whether you're talking about community health workers. I saw a couple posters, I was really excited to see the ones about that. You look at things like doulas. We know that we've got maternity health deserts across our state. There's a shortage. Doulas have shown time and time again to be effective. There's an opportunity there. So, we also have to take a look at, especially our organization, we have folks that are seeking employment. So what can we do to help encourage these emerging careers? We have kids coming out of foster care, limited support systems. How can we push them to some of these career opportunities, whether it be a paramedic, whether it be a doula, whether it be a community health worker? A lot of opportunities out there, but the thing that Kim touched on is the funding aspect. So we've seen it time and time again. You've got to get the funding, you've got to have a proof of concept, you got to get the data, show that it works, but then what? I think that's been a challenge with the community health workers is we try to build it and hope the funding comes, and it's a unique thing for me to say from a payer perspective, but I think there's definitely been some missed opportunities there because it works, it's effective, it lowers the overall cost of health through the life of the member. So how can we better support that?
I should have also mentioned that Appalachian Regional Commission has Power and Inspire and Arise grants, and health is underrepresented in these awards. And we really should be doing workforce awards. They did fund one recently for foster care transitions and employment. So you made me think of that, Pat.
Yeah.
One of the other areas I think that kind of loses the focus is it's the community paramedicine, right? So it's not just what's going on and what's in that community today, but how can you bring that care into the community through partnerships? So community paramedicine, I think, is an area that we need definitely to look at, especially with just the way our state's laid out. And then think about the services that can come through that, right? This is not just the paramedic that shows up because your grandmother's down and we've got to get her to the hospital. This is the paramedic team or paramedicine team that's coming into the community to either deploy vaccines, to do diabetic eye screenings. It's those wellness initiatives, and if the wellness initiatives are addressed, the other things tend to take care of themselves because the person becomes healthier. So I think it's also looking at those types of paths, and then how that team is built out, I think, is key.
Thank you. All right, anyone else want to add anything to that? Sure.
I'll just add too that, all this is driven by data, right? we need those data analysts, we need those IT,
Yes.
guys, IT and data analysts, from the time they're in college, you know, we're partnering with our higher education institutions, our high schools even, to let them know there are career opportunities available, because it's not just an insatiable appetite for the data that drives the population health piece, right?
Absolutely. I think as we look at careers, a career pipeline, there are ways to get into healthcare and population health that, again, like Kim said, is not going into nursing and not going into medical school, but it rather is tapping into some of those other skills and interests that people have, and data is a perfect example. I have a son who's a data analyst, and I remember when he was in, 8th grade, he said, "No offense, Mom and Dad, but I will never do anything in healthcare." And he's a data analyst. He could very well be doing healthcare data analytics, but it's an opportunity for people who are that never healthcare group. Yeah, good. Thank you. One of the things that we talked about in our pre-meeting in relationship to this topic was the need for kind of standardized education and competencies and skills, the need to really look at how we can sustain these through reimbursement, the need for perhaps certification in some of these areas, and then some sort of regulation or registration mechanism if that's needed for reimbursement. And I think in this state we have some experience with that with peer support specialists who are now have a standardized education, they have a certification, they will have a way to be reimbursed. So we do have some experience with that. You all in the room, if you have ideas about how we do that, you have 2/3 of the leadership of the new DHHR in the room with you. So we'd be glad to talk with you all about that as well. So I'm going to throw this over to Chad, and so as an employer who is recruiting a workforce to do population health work, what do you see that's missing from the people who come to you that might be critical for the future of your work? And then how do you think higher education can innovate to meet those needs for that population health workforce?
Yeah, Secretary, you and Terry actually perfectly teed me up for one of the answers I was going to give, and that is, the data analytics piece. That is huge. That seems to be a real missing component in everything that we're talking about. One of the best data folks that we have came out of the banking and finance industry. So we worked with him probably a year on, like, this is what healthcare is. This is what this code means. This is what an MLR is, just kind of taking it from a boot camp type perspective. It would be great if we didn't have to do that, if we could flatten that learning curve. So, this is, I think we've all made the point that when you're talking about this subject, it's a really big circumstance. And there's a lot of different jobs, whether you're talking about community health workers or whether you're talking about MD programs and the core competencies that they are coming out of medical school with. I mean, that's another issue. We have our best medical director right now. He was an ER physician. Like, this was a new concept to him. He got it, he lived it, he breathed it, but these terms, how we look at data, it was new. So again, anything that we can do to introduce these concepts early on in an education program is going to pay dividends.
Terry, I would totally agree with you, Pat, because we talked about this just yesterday on our team, because we've got tons and tons of data, right? And we've got data analysts who can pull tons and tons of data, but they're missing the piece of understanding the data, right? So it's great to be able to run queries and write code and sequence, and I am not IT, so I will use terms that are so inappropriate. But you have to understand, and you have to understand the why. Why are you asking me for this, Michelle? What are you really looking for? And I think that the more we can teach that early on, when they come out and are in that workforce, you're gonna lose that boot camp period because they're gonna come hitting the ground running.
I see some of our colleagues from Glenville State College, or State University, who are here. And we had some conversations a number of months ago about what are the emerging health professions as they develop their school of health sciences at Glenville. And we talked about that. We talked about you need analytics. You need to have people who understand both healthcare as well as data analytics, because that connection and being able to draw a line between the data and what it really means to a community is so important.
I just wanted to throw out there that Workforce West Virginia really runs all of these reports on what's the current situation, what jobs are open, what do we need. So if I was studying in a career and technical or a college, university, I would be, and when you say Glenville, it made me think of this because Glenville got the power grant for the cybersecurity. And when we saw it was like cybersecurity, I hadn't thought about that. But when you looked at, they looked at the data. They said, okay, here's the data. We need these folks for the FBI center. We have this many jobs. We have people that will hire them, but we have to train them. So I think it's that innovation and those bodacious ideas that you just don't say, well, there's a problem that we're losing dialysis across the state. So why are we losing dialysis? And how do we say, oh, well, it's all private. We can't do anything about it. So we're just gonna let people die? So no, that's not the answer. And I'm sorry if you've been to a dialysis center, it's 20 FARPA loungers and people that sit and monitor them. They have to have nurses, but how do we create our own in West Virginia? How do we figure that out? So I think thinking outside the box and being innovative.
Anyone else? Deb?
I'll just add is, I think the challenge for all of us as we think about building a population health workforce, competencies, foundational education, how do we integrate and make sure that there is the appropriate education on health equity, on health disparities, on the social drivers of health, on working in rural communities, on Appalachian culture. So those types of things as well. So they're going to be important.
Thank you. Terry, did you want to add anything?
No.
Okay, good. Well, Terry, I'm going to jump to you then, and then throw this out to the group. So what are the critical shifts in mindset or resources that we should begin to build now in order to really build that population health workforce?
Well, as we move more towards population health, we have to really change two main things. One is the delivery system, the delivery models, and the other is the payment model, right? And so, what keeps our folks in West Virginia, Pat hit on this a little bit, what keeps our folks in West Virginia from seeking out healthcare, from coming to the doctor? Part of it is our Appalachian, attitude that we want to, we are resistant to it because we don't feel like we need it. Another part is what happens when you show up at the doctor's office. You take your kid to the doctor, your child is sick, what's on your mind is your sick child. What's on the mind of the people when you get there is getting you registered, filling out forms, getting their payment, and then you don't know how much it's going to cost, you don't know how long you're going to be there, and you feel like, hey, they just want to get the payment out of me. And because we're volume based, right? We're fee for service. So as we move to that pay for value and for outcomes, it takes more than just that healthcare provider. It takes partnerships built across communities. It takes a lot of things. So has anybody ever seen the shaky bridge analogy they talked about? Where healthcare providers have one foot in the fee for service side of the house and the other foot in the value-based side, and it's a risk there because there's an uncertainty, there's an unknown on that shaky bridge. You can't step totally over here until you know you're going to land on solid footing, right? So until we get to that point, we're not going to be able to change the mindset of our people to be able to come into a health facility. It shouldn't be strange to them that they come there. It shouldn't be, we shouldn't act like, it's the first time we've seen you, we're going to have you fill out 3 or 4 forms every time you come in, no matter what, right? How many of you have been asked, hey, don't you have my information from the last time I was here, right? That happens all the time. So I don't want to go to a doctor's office or to a hospital or any kind of healthcare setting because I don't know how long I'm going to be there. I'm going to be sitting in the waiting room. It may take me 15 minutes to get through, it may take me 2 or 3 hours, right? I don't know how much it's going to cost me, so I have a fear of going there. And then you add on top of that our Appalachian roots here that says, I'm good, I don't need help, right? We hear that from our patients all the time. So in order to change that mindset, our workforce needs to change their mindset. They need to understand how that patient is feeling when he comes to the door, right? So we can do this through partnerships, I think, through, communities that are building kind of health and wellness destinations, and we have some folks that are doing that, right? We have some of our FQHCs and our hospitals that are building wellness destinations. People are accustomed to them coming to the hospital or coming to that destination, and they don't feel like a stranger to the place. So we need a workforce that understands that. We need, when I talk about partnerships, we need communities and community leaders that understand that they're part of the population health picture, right?
I think that, you saw in the videos, and we've alluded to this, that this is where population health intersects with policy, right? A huge change to the way that healthcare is paid for would be to do value-based payment, which we are certainly doing some of. But if we made that full shift, do we have the workforce that understands how to work in that kind of environment? Thanks, Carrie, for sharing that perspective. Kim, were you gonna say something? No?
No, but I could, I mean.
You look like you were on the edge of your seat.
I just want to give the example that when we talk about, Deb and I had the honor of talking about the community health worker program at the National Rural Health Conference this year, and we had 6 different states come up to us and go, how did you do that? And want us to come and tell them how to do that. And what they were most amazed with was our relationships with our MCAs, that we talk to them. And I think it's a mind shift that some people think, oh, they're the payers and they're bad people, and or they want to do something to us, or we don't want to tell them things like we don't want to go and tell mom and dad we did something wrong. And our payers are amazing, and to just go and say, and Unicare, I'll give you this example. Recently, we started adding that, I guess HEDIS measures got added around oral health, and there used to be 1, and now there's 6, I think, and I could be wrong, but there's more than 1. And so they reached out to the Oral Health Coalition and said, help us figure out how to meet these HEDIS measures. They have the same goals. We want to improve population health, we want to reduce cost, and we want to improve quality. And then that's how we made the model work, because we learned, took me a couple years, but I finally learned, just go ask them.
Right.
And other people in other states don't have that. That's when West Virginia, being as small as we are, really is an asset.
We can be a laboratory for change.
Yes, we
We
can.
absolutely
And
can.
innovation.
Ted, I want to ask you on this topic to talk a little bit about how we're using our Medicaid dollars. I would be remiss if I didn't talk about Medicaid dollars. The Secretary who oversees Medicaid. But Todd and I had the opportunity to sit down last week and talk about how some flexibility with Medicaid dollars has allowed them to do some really great community-based projects. So,
Yeah,
can
absolutely.
you talk about that?
Yeah, absolutely. One of the things that the Medicaid agency, BMS, extended some flexibilities to us a couple years ago in our contract that allows us to make community investments, and we can count that in our MLRs. So, not to get too much in the weeds here, but the MLR is a calculation of premium versus expenses. We have to meet certain thresholds. So this gave us an ability to invest in some different health equity-based projects. One of the things we did was we worked with HealthRight on the Charleston's west side around a mobile clinic to address HIV screening, and we've seen some great results. They built a clinic over there that we supported as well to better serve that community that has been chronically underserved. We worked with the Marshall's Minority Health Institute on some different health equity initiatives. There's some great results coming out of that. So West Virginia has really, I've given several talks nationally, both internally and externally, on the proactive nature of West Virginia's Medicaid program and the great things that we've been able to do. It's made a huge difference.
I think it's been proven in your outcomes too. That you're seeing some pretty phenomenal outcomes from that flexibility. So again, where population health and policy bang up against each other. Somebody in our planning mentioned broadband, speaking of policy issues. Anybody want to talk about how enhancing resources for our workforce through broadband would really push us forward?
I could just mention both for the community health workers and for the local health departments, we talk about this, and we learned a lot again around this topic of reaching people through COVID. And I would challenge all of us, we talk about 5 social drivers of health, and typically that's, your financial instability, your food insecurity, your transportation. We have 7 in both of these settings that we use, and one of those is digital access. And the second one that complements that is digital literacy. Just having access does not mean that they are able to access the information that they need. And then the other one is social isolation, particularly in our rural communities. And we all know, I think, the tremendous impact that can have on health. So I think we have to continue to push the envelope and think about what does our population need in terms of social drivers of health.
There are a lot of people that are trying to, until we solve the internet connectivity issue, we're gonna stay behind in everything. Education, healthcare, everything. And we all know, anytime I go to Williamson, I'm just saying, don't try to find me, because even if I take my hotspot and my phone with different carriers, you can't reach me. So as a state, there are some shining spots. They've announced a lot of money recently in the Department of Commerce, and Mitch Carmichael is the person that you could contact there. And then Generation West Virginia has really been working on the development of new ISP providers and new opportunities. And so I think that that's some shining spots. There's dollars at ARC and USDA, and we're set aside state for USDA dollars, so we have 3 reps that have been added to West Virginia to help us find money, and this just needs to be everybody's priority. And then I won't say his name because he might kill me if I say it, but I was at one of our academic medical centers yesterday talking to one of our doctors, and he's gonna try Skylab. He's gonna buy them and bring them in, and we're gonna do a little pilot. It's $600, it's 30 pounds, you just need a piece of sky, it doesn't even have to be blue, plunk it down. I said, give it to me, I'll take it to Williamson and see if I can go up the holler with my community health worker and see if we can do this. But if that's what it's gonna take for the last miles of McDowell's and Mingo's, then so be it.
Yeah,
And we need a healthcare workforce who thinks like that, right?
Yeah,
We
exactly.
need people who are thinking in innovative ways and different ways so that we can get to that end point of being able to reach people where they are.
Yeah, that's a great point, and I think, from a payer perspective, oftentimes when we're talking about broadband limitations, it's through the lens of telehealth, telemedicine. But one of the things that we're not really thinking about is, if you look at it through the lens of SDOH and employment opportunities, think about the limitation. Think about the remote jobs post-COVID that are out there that aren't accessible to folks in our rural communities. So it's a significant issue.
I remember about 25 years ago, a legislator said to me, you nurses, you only come to the legislature when it's about you. And quite frankly, it was true. We didn't come out around broadband that impacts health. We didn't come out about Medicaid policy that if it were flexible, it could help us do other things. And so all of us need to be thinking and instilling in students, if we have exposure to them, how healthcare bumps up against policy and how we should be advocating for things that are not traditionally healthcare. So broadband, I think, is a perfect example.
Yeah, one more thing about broadband is the affordability, right? We consider it a necessary public utility now, and a lot of people are not gonna be able to afford, $110 a month, fiber or cable connection to their home. And so it does, limit them on their ability to have there are tons of remote jobs out there. We've got more remote workforce than we've ever had. And so it does limit them quite a bit, the affordability of that. So we need to do something to also bring the cost of that down.
There are subsidy programs, so maybe we need to take students on an internship and have them go out and sign up people like we used to on census, and really get people on these $30 off a month for the program.
Right.
I don't know.
And all this, the community health workers do assess that at every single home visit, and they do offer to help them enroll, but what we are learning is it's still too expensive. So there's still more work to do, and they still have to make choices between food, or car payment, or gas, and
We do a lot of remote patient monitoring, but there's areas we're not able to do that. So even from a health and wellness standpoint, to be able to have those tools work, they're not there. So broadband's a very big issue.
I live in Canal City in Charleston, and my broadband is not the best.
I have spots in my house. in
Let's talk
Charleston,
about
right?
Williamson. I mean, let's
Yeah,
talk
yeah.
about McDowell County, let's talk about Welch, you know, those are, those are the places where we need to be really thinking about how bumping up against broadband issues also is a healthcare, driver. Well, first of all, I wanna say thank you to all of our panelists. You all did great. You knocked it out of the park to really get us started and thinking about what that workforce of the future needs to look like. We're gonna have plenty of other opportunities as we go through the day to start putting some meat around those bones that you just presented. So I appreciate it. I think we went over our time and into our break, so you want a 10-minute break? A 10-minute break, and then we'll resume with some information about